of Laerdal Medical and the American Academy of Pediatrics, we welcome you to today's presentation. We're really glad that you are here and that you chose to spend time with us today to learn more about this very important topic, preparing for preterm births through neonatal education. My name is Lee and I'll be your host today. The goals of this presentation are to review prematurity and its impact worldwide, to talk about the impact of the Helping Babies Survive programs, to discuss neonatal education training that will help ensure safe and successful outcomes for premature infants. And finally, we're going to talk about simulation and how the use of simulation can benefit neonatal resuscitation training. I'm excited to introduce our speakers today. We have three leaders in the neonatal healthcare profession joining us. We have Jeanette Zeichkin from the Seattle area. We have Maria Strand from St. Louis. And we have Eric Amick from Chicago. I'd like to now welcome and invite Maria to begin the presentation.
Hello, everyone. I hope everyone can hear me okay. Thank you for joining us today. Let's begin by getting grounded in some of the basic facts about prematurity. A term pregnancy is considered to be around 39 to 41 weeks of gestation. A premature birth occurs before 37 weeks, and the more premature the baby is, the higher the risks of complications. Most preterm babies are born at more than 34 weeks of gestation. This means that the birth of a very preterm infant, one that is born many weeks earlier, is a high-risk event that does not happen very often, except possibly in regional medical centers. That means that most healthcare professionals need to learn and, more importantly, need to practice the technical skills and teamwork necessary for efficient and effective resuscitation of preterm newborns. Unfortunately, preterm birth is common worldwide. About 15 million babies are born preterm, and nearly 1 million babies die because of complications related to prematurity. In the United States, the preterm birth rate was 9.6% in 2014. This means that we can expect about 1 out of 10 live births to be preterm. While the U.S. preterm birth rate ranks among the worst of high-resource countries, the rate has decreased 8% since 2007. Racial and ethnic disparities exist in preterm birth in the United States. Black infants are about 50% more likely to be born premature than white, Hispanic, and Asian or Pacific Islander infants. While the highest cause of infant mortality varies in different states, overall, premature birth is the United States' greatest contributor to infant mortality. Globally, across 184 countries, the rate of preterm birth ranges from 5% to 18% of all births. On this map, the darker the color, the higher the rate of preterm birth for the year 2010. The list of countries on the right are the 11 countries with preterm birth rates over 15% by rank. The majority of preterm births, more than 60%, occur in Africa and Asia. More than 90% of babies delivered at less than 28 weeks of gestation and born in low-resource countries will die within the first few days of life. Globally, prematurity is the leading cause of death in children under the age of 5. And in almost all countries with reliable data, preterm birth rates are increasing. Why do these infants die? Looking at the chart, the three main causes of newborn deaths are complications from preterm birth, neonatal infections, and complications during childbirth. In low-resource settings, many babies die due to a lack of feasible, cost-effective care, such as warmth, breastfeeding support, and basic care for infections and breathing difficulties. Solutions for preterm birth should focus on preterm labor management, improved resuscitation practices, kangaroo mother care, and alternate feeding techniques for babies who have difficulty nursing. Interventions for all babies that would decrease infant mortality are related to cord care, hygiene, and exclusive breastfeeding. Helping Babies Survive is an initiative that comes from the American Academy of Pediatrics, Laerdal Global Health, and other partners. Their collaborative work led to the much larger worldwide effort to improve neonatal health, known as the Survive and Thrive Global Alliance. You're probably familiar with Laerdal Medical. Laerdal Global Health is a new company created especially to help developing countries significantly reduce infant, child, and maternal mortality. Building on the success of Helping Babies Breathe and Helping Mothers Deliver initiatives, a goal for the new company will be to introduce 10 to 15 innovative products over the next 3 to 5 years, focused on the needs of the mother and the baby on the day of birth in low-resource settings. The products aim to be culturally adapted, highly affordable, durable, and simple to use. Helping Babies Survive programs have been implemented in over 70 countries worldwide, targeting the Millennium Development Goal countries. These countries are 75 countries in the United Nations targeted with 8 goals to improve health by 2015. Helping Babies Survive focuses on goal number 4, to reduce child mortality. With 2015 winding down, the United Nations recently adopted a new target for 2030 called the Sustainable Development Goals. Goal number 3 of this program, titled Good Health and Well-Being, strives to ensure healthy lives and well-being for all people and works on maternal and child health and safety. Helping Babies Survive is a suite of 3 educational programs designed to improve neonatal survival in resource-limited areas. Helping Babies Breathe training focuses on keeping babies alive through the first 5 minutes of life. Essential Care for Every Baby picks up at minute 6 and emphasizes the care that babies need throughout the first 24 hours. Essential Care for Small Babies has an expanded set of considerations for babies born under 2,500 grams who have temperature and feeding problems. Cup feeding and nasogastric tube feeding are used as alternatives to nursing at the breast. The goal of this program is to maintain the wellness of a small baby that is born fairly healthy. Because Helping Babies Breathe has been in use for the longest of the 3 educational programs, we have documented success for HBB. In Ethiopia met its goal to reduce child mortality ahead of its 2015 target. In India, more infants who previously would have been considered stillborn were successfully resuscitated at birth. And in Tanzania, neonatal mortality dropped by 47% after nationwide implementation of Helping Babies Breathe. Looking at the United States, about 380,000 preterm babies are born each year. The March of Dimes issues a premature birth report card each year, and in November of 2015, the March of Dimes gave the U.S. overall a grade of C. The purple states received a grade of A, the blue states got a B, and the yellow states got a C. The orange and red states were graded even lower. While we have made progress in many areas of premature birth, there is still much work to be done in the U.S. and worldwide to decrease premature birth. Learning and practicing how to care for premature newborns in the delivery room is key to their survival and their success. Now, Jeanette will take us through the education and tools that help healthcare professionals give premature babies their best possible start.
Thanks, Maria. Waiting for the slide to change. There we go. Let's start with a brief review of NRP, what it is and what it is not. As you know, NRP is now the standard resuscitation training for healthcare professionals who manage newborn in the hospital setting. NRP introduces the concepts and skills of neonatal resuscitation. It's not a certification course, and it doesn't certify anyone to do anything. The success of resuscitation depends on cognitive, technical, and behavioral skill development. NRP cognitive knowledge comes from studying the textbook of neonatal resuscitation. Cognitive knowledge is assessed by taking the online examination, and in 7th edition NRP, everyone will practice the sequence of NRP flow diagram by completing 3 eSIM exercises. You can see our eSIM premature baby here. I believe this is baby Chris, who is patiently waiting for a virtual resuscitation. Technical training, which is the hands-on component of learning resuscitation skills, can happen at the in-person NRP provider course, where learners may practice skills with help and guidance from an instructor at performance skill stations, and then demonstrate their ability to perform skills in NRP flow diagram sequence during the integrated skills station. NRP moved from a PowerPoint-based methodology to a simulation-based methodology with the launch of NRP 6th edition about 5 years ago. Although some NRP instructors had little experience with simulation and debriefing, most NRP instructors are now comfortable with this method, where learners are immersed in an environment that resembles their actual clinical setting as closely as possible and feel safe integrating their cognitive and technical skills with teamwork and communication strategies that improve patient safety. Where the NRP provider course may include practice and review of technical skills, such as positive pressure ventilation and medication administration, the simulation and debriefing component of the course focuses on teamwork and communication. These 10 NRP key behavioral skills are critical to successful resuscitation. Even though team members may be competent with technical skills, they will not be able to use these skills if they can't communicate and coordinate with each other while working under the intense pressure of a high-risk event. Debriefing is the discussion that comes after the scenario in a simulation exercise. The instructor asks open-ended questions so that learners can talk with each other, self-assess their performance, and focus on what contributed to things that went well and what needs improvement. Conducting a scenario requires extensive preparation, as the instructor first assesses the learner's needs, formulates learning objectives, and then facilitates the scenario. However, debriefing is actually when the learning occurs. Resuscitation of premature infants takes particular practice in management and teamwork. Simulating resuscitation of a very premature newborn has been hampered by the lack of a model that looks and feels like a premature baby. Prematurity solves that problem and allows the team to practice management techniques and team dynamics during resuscitation and stabilization of the very premature newborn. Prematurity is designed to be 25 weeks gestational age and about 750 grams. She was developed in collaboration with the American Academy of Pediatrics. You can read about the development of Prematurity in the fall-winter edition of the NRP Instructor Update, located on the NRP webpage. Prematurity is designed to support NRP training for delivery room resuscitation and stabilization of an extremely premature baby. Prematurity is available in 2 models. Both are designed to be 25 weeks gestation and about 750 grams, although instructors can certainly tell learners that she is any gestational age that is believable for a simulation exercise. The task trainer allows ventilation with a face mask or endotracheal tube, has chest movement with PPV, allows insertion of an OG or an NG tube, allows chest compressions, and insertion of umbilical catheters. The Prematuryan with SimPad Plus also has heart sounds, breath sounds, facial cyanosis, grunting and crying sounds, external monitoring of vital signs, and a set of pre-programmed scenarios. Seventh edition NRP teaches these interventions for resuscitation of newborns less than 32 weeks gestation. In preparation for premature Anne's birth, you would discuss the plan for umbilical cord clamping with the OB provider, increase the temperature in the room where resuscitation will take place, and activate the thermal mattress. When premature Anne arrives at the radiant warmer, you would cover her in plastic wrap or place her in a bag, put the hat on her head, place the skin temp sensor on servo control to help maintain a normal body temperature, use a device that provides PEEP and CPAP for respiratory support, start PPV with up to 30% oxygen, and use pulse oximetry to guide oxygen concentration per target saturation guide. Consider using a cardiac monitor for the most accurate heart rate assessment. These interventions are based on the most current science, and when used in combination with proficient technical skills and effective communication, help ensure the best possible start for the very preterm newborn. Realistic practice with high levels of fidelity can lead to improved team function in neonatal resuscitation. Your efforts to reduce infant mortality by contributing to proper resuscitation and care of preterm babies makes a difference in your institution and in the world. Whether you're an NRP instructor, NRP provider, an administrator who supports the program, a healthcare provider in the NICU, or a person who teaches newborns care skills across the globe, you make a difference by helping to ensure that premature babies get the care they need to reduce the risk of complications. Through training and education, we can improve outcomes for these tiniest of patients. Together, we'll continue to search for solutions to decrease the rate of preterm birth and for strategies to make education and training accessible and culturally appropriate both at home and around the world.
Thank you, Maria and Jeanette. Next, we're going to have our speakers address and answer some commonly asked questions. Due to the large audience today, we're unable to facilitate live Q&A. However, we would like to address some common questions that many of you probably have. And I'm going to turn the over to Maria now, and she'll go ahead and address some common questions. Maria? Okay, Maria, you can go ahead and address some common questions. Maria, you may be muted. We're not hearing you speak. Maria, are you there?
Lee, do you want me to step in for Maria until she gets back on?
Yes, that would be great, Jeanette.
Okay, why don't we do that? And I'm sure Maria will be back on. We must have lost her. Okay, so we have some common questions here that we thought might be helpful to answer for you. And if we can get to the next slide, we're going to start with some global health questions. And Eric Amick is going to answer the first question, which is, how can I become more involved in helping babies survive? Eric?
Eric, you would may have to unmute yourself. There you go, Eric.
Lee, can you hear me?
I can hear you, Maria.
Oh, good. But now we can't hear Eric.
Technical difficulties, that's okay.
So, Jeanette, were you able to ask the question of how to become more involved in helping babies survive?
I asked the question, and we're waiting for Eric. So do you want to move on to the other questions until Eric gets back on?
Yes, I do.
Okay.
But I can't advance the slides.
Okay. Go ahead, Maria.
Okay. Another question that we often get is in regards to the Laerdal Global Health products. I mentioned in the slides that there's a plan to introduce innovative products for mother and baby on the day of birth. And one question that we address is, have any of these products been developed yet? Yes is the answer, and on the next slide are a picture of 4 different products. Lee, can you advance?
Yes. Okay, go ahead, Maria.
It doesn't want to advance for me.
Okay. Is that where you want to be?
That's where I would like to be. So you
Okay.
can see 4 different products. The one on the top left is the Moya fetal monitor. That is a low-cost, durable, portable fetal heart rate monitor that can help to differentiate when a fetus may be in trouble before delivery. An interesting nuance of this device is that it also has a maternal heart rate monitor, so that when the mother holds the device, it will assess her heart rate so that the 2 different pulses can be differentiated. Below that picture is an upright resuscitator, which is a disposable few-piece bag valve mask apparatus that is inexpensive and has been utilized in low-resource areas. The few pieces means that you can take it apart and clean it and reassemble it. And additionally, it may help to decrease mask leak with its upright design, but that is still being investigated. On the top right is the Care Plus swaddling device. It is a thermoregulatory device that is worn by the mother and facilitates skin-to-skin care to promote normothermia for premature babies. And then finally, on the bottom right is the breastfeeding task trainer that's worn by a stand-in, and the lactation consultants can work with the moms and not only learn more skills when it comes to lactation support, but demonstrate for mothers as well in a culturally sensitive fashion. Let's see if we can go ahead. There. There are 2 models of Premature-an that were mentioned by Jeanette, and sometimes there's confusion regarding the advantages of one model over the other. Jeanette, would you be able to address if there are some advantages that different consumers should look for in different situations?
Sure. At the NCE last October, we had both models at the exhibit, and people really had a lot of fun playing with them. Premature-an is in 2 models, as we mentioned. The task trainer allows ventilation with a face mask or an endotracheal tube, excuse me, has chest movement with PPV, allows insertion of an OG or an NG tube, allows chest compressions, and insertion of umbilical catheters. The Prematuryan also, with the SimPad Plus, has all of those features, but is electronic. So the SimPad Plus has heart sounds, breath sounds, cyanosis on her face. She can make grunting and crying sounds. She has an external monitor for vital signs that a simulation tech can control, and she comes with a set of pre-programmed scenarios. The task trainer is less expensive and designed for skills training. But if you use the task trainer for simulation, the instructor must convey Prematuryan's vital signs by some method. So in other words, the instructor needs to tell the learner about Prematuryan's heart rate, oxygen saturation, spontaneous breathing and muscle tone, and crying, and color if that's appropriate. Using Prematuryan with SimPad Plus means that the instructor doesn't have to instruct or interact much with the learners. So the instructor doesn't have to say what the baby's vital signs are, because vital signs are on the monitor and the baby cries and grunts. So the SimPad Plus model is designed specifically for team training and scenarios. But both are realistic models for premature newborn at 25 weeks gestation, and both models have the newly designed, really great realistic airway for intubation.
Great. Let's see if we can get to the next one. Okay, so let's say, Jeanette, that I've been using a neonatal mannequin like Newbie as part of my NRP curriculum and educational programming. So how does Prematuryan support the NRP curriculum, and should I think about using both mannequins, or is one mannequin enough? What are your thoughts on that?
Well, we started integrating simulation-based training into the last edition of NRP, and Newbie was designed for use with that NRP curriculum. Even though we can suspend our disbelief during simulation and imagine that some of the less accurate clinical cues are real, imagining that Newbie is an extremely preterm newborn stretches our suspension of disbelief capabilities to the limit. So neonatal providers have been asking for a realistic premature mannequin or simulator for many years. Finally, the timing was right, and the AAP and Laerdal Medical collaborated to design a premature simulator for use in scenarios where the learning objectives involve resuscitation of an extremely premature newborn. So Prematuryan supports the NRP in that preterm babies are more likely to require resuscitation than term babies. So Prematuryan allows you to use a realistic model for scenarios involving preterm infant stabilization, and preterm infant is one of your learning objectives for resuscitation and stabilization. It makes a realistic model in either place. You can also use Prematuryan for end-of-life scenarios. In answer to the question, should be using both? Well, that's a hard question, and no one can really answer that for you. Newbie and Prematuryan both support the learning objectives of the NRP curriculum. Prematuryan supports the learning and the hands-on practice required to respond to the specific anatomical and physiologic complications unique to a 25-week infant. But remember that the quality of your simulation program doesn't depend on the technology. If your instructors are unskilled or your curriculum is not planned with the needs of your learners in mind, a nicely designed simulator or mannequin is not going to result in a high-quality course. So first comes well-prepared and knowledgeable instructors who have assessed the needs of the learners and then set up the scenario using all of the resources that you have available to make it resemble the actual clinical setting as closely as possible. If Prematuryan can be part of your simulation training, you're fortunate to be able to present a great solution to the challenge of resuscitating a preterm infant that realistically looks and feels like a premature infant.
Our slides are on self-control here.
I'm not touching anything, honest.
No, I know. Okay, another question is related to the March of Dimes data, and I'll try to address this, about where a provider could get more information about the premature birth report cards, and what are some of the key findings, and how do they come up with those data that are presented. So the March of Dimes premature birth report card grades not only states, but you can also find data about cities and counties in the U.S. as well. The state's grades are assigned by comparing the 2014 preterm birth rate in a state or in a locality to the March of Dimes goal of 8.1%, which was set for 2020. The cities with the greatest number of births in the state are graded based on their 2013 preterm birth rates, and the grading methodology is explained in a lot more detail on their webpage, which is on our references slide coming up. Portland, Oregon has the best preterm birth rate of the top 100 cities, with the most births nationwide being 7.2%, while Shreveport, Louisiana has the worst at 18.8% according to the data analysis. On the map, Idaho, Oregon, Vermont, and Washington were all states that earned the grade of A. I think it's also important to recognize that the report card revealed persistent racial, ethnic, and geographic disparities within the country and within states as well. So on the March of Dimes website, which is marchofdimes.org, you can find much more information and data about your location as well. I think this is an interesting question, Jeanette, and I hope that you can answer it for us. Delayed cord clamping in an extremely preterm newborn can be a challenge clinically, and being able to practice it can be very helpful to care teams. Can you walk us through, because I know you've taught this, can you walk us through how you simulate delayed cord clamping with a prematureen mannequin?
Sure. We worked on this and got some opinions from across the country because a lot of people aren't doing delayed cord clamping yet. And so we had to figure out how to coordinate this between neonatal providers and OB providers. We know that delayed cord clamping has been associated with improved cardiovascular stability, increased blood pressure, decreased need for blood transfusions, a decreased incidence of IVH, and a decreased incidence of NEC. For vigorous preterm infants who have intact placental circulation, cord clamping should be delayed for 30 to 60 seconds. So what we decided to do was discuss this with the OB provider first, and this is why simulation is great to do along with your OB providers, because that sort of delegates the roles and responsibilities with Prematureen instead of a live baby. The initial steps of newborn care can be performed with the umbilical cord intact, such as clearing the airway if necessary and providing gentle stimulation. So the OB provider or the neonatal provider, depending on what you decide, covers the infant with a warm blanket or plastic wrap to maintain temperature while the cord is intact. So to simulate delayed cord clamping with a mannequin, we put the clamped umbilical cord into the mannequin's abdomen as usual. Then we used a long simulated umbilical cord, either one from a manufacturer or a braided rope from a Home Depot store. Mom holds one end of the cord under the blanket, and the OB provider holds the other end against the baby's abdomen. Then the OB provider simply announces that the cord has been clamped and cut and lets go of the long cord segment. There's no clamping and cutting that actually happens. The OB provider simply lets go of that end of the cord, and then the baby is free to move to the radiant warmer and already has a clamped umbilical cord in the abdomen. And that's where you would finish your initial steps and get started with your next interventions. Well, it works pretty well.
Great. Well, with an eye on the clock, I think I will hand this back over to Lee, who I know has some wrap-up and additional questions for the webinar participants. Lee?
Great. Thank you. I just want to, again, thank you for your time today. Thank you for your presentation, Maria and Jeanette. And we do want to be respectful of everybody's time. So we're going to actually end our Q&A unless we can get Eric back on to say any few words. I'm not sure if Eric had a technical problem today. Okay, so we're going to end our Q&A time, and I'd like to, on behalf of Laerdal Medical and the American Academy of Pediatrics, I'd like to thank all of you who joined our webinar today. But we're going to continue, and I'm going to